Good morning, good afternoon, good evening. I am Annette Wineza, a medical doctor with a PhD in human genetics, director of Allied Health Services in CHK, senior lecturer in human genetics at the University of Rwanda. I have the pleasure to be a speaker in the African Oncogenetic short course. I will discuss about cancer genetics in Africa, especially about the ethics and cultural context in Rwanda and in the continent. So this is the outline of my study. I will start by a brief introduction about the statistic of cancer worldwide and in Rwanda. Then talk about the Rwanda healthcare system, the cancer genetics, the genetic testing of inherited cancer, and ethics of genetic testing of inherited cancer in Rwanda and Africa. Worldwide, cancer is among the leading cause of morbidity and mortality. According to the 2020 global scan, there were approximately new cases with 5.7 Africa, with 5.7 from Africa. Female breast cancer was the most commonly diagnosed cancer with an estimate with 2.3 million new cases. According to the Rwanda Biomedical Center, there were approximately 4,800 new cases diagnosed in 2020, and breast cancer was the most diagnosed. The situation in Rwanda in July 2018, the Ministry of Health RBC established a national cancer registry. Information collected on cancer cases presenting at health facility, as well as cancer death occurring in the community. Here we have a figure showing the data which were available in the current database, show a concerning trend with a significant increase of cases over the years from 634 new cases in 2007 to 4,819 cases in 2020. So in 2020, among the 4,890 cases, breast and cervical cancer represented respectively 14% and 13% of all cancer combined. So the Rwanda health system structure is built on the Ministry of Health, and the cancer unit is under the Division of Non-Communicable Disease at the Rwanda Biomedical Center and is responsible for setting and implementing cancer care policy. So the healthcare in Rwanda is predominantly delivered through public hospital and private sector. The healthcare sector is organized around the tertiary university teaching hospital and provincial referral hospital, district hospital, health center, and health posts, and the patients are referred from the bottom to the top, from a health post to the university teaching hospital. And more than 80% of patients are covered by the community-based health insurance or mutuelle de santé. So the diagnosis of cancer in Rwanda, the infrastructure for diagnosis and staging of cancer are available in tertiary teaching hospital and the Butaro Cancer of Excellence. The diagnostic capacity consists of pathology, laboratory, endoscopy, and radiology. The center providing the pathology services have CHK, CHUB, King Faisal Hospital, Rwanda Military Hospital, and Butaro Cancer Center of Excellence. But there are currently no advanced pathology services. That means diagnostic molecular pathology and genetic testing of inherited cancer in the country. So the three teaching hospitals are located in the city of Kigali here in the middle. We have the Rwanda Military Hospital, where the first cancer for radiotherapy, the first center for radiotherapy is located. We have CHK, the biggest public hospital in the country, and we have the King Faisal Hospital. So we have the Butaro Cancer Center of Excellence, which is a public specialized tertiary care medical facility and located in northern province of Rwanda, approximately 96 kilometers by the city of Kigali. And in the southern province, we have the University Teaching Hospital of Butare. So the treatment of cancer is provided at tertiary level facilities. We have 5 hospitals. The 5 hospitals are delivering cancer care in varying capacity. The cancer treatment capacity consisting of surgery, chemotherapy, and radiotherapy. The government of Rwanda have built the human resources since 2013 at the University of Rwanda. We have the Masters of Medicine in Anatomical Pathology. As 2020, 19 pathologists have graduated and are now working in public hospital in Rwanda. We have a Masters of Science in Nursing, Oncology, 11 certified radiologists, 3 medical oncologists, and 1 pediatric oncologist, and 2 medical doctors with a PhD in human genetics. Cancer genetic in Africa. I retrieved some publications. For example, review of cancer genetics and genomic study in Africa done by Rotimi in 2020. Found that there is a wide knowledge gap in understanding the underlying genetic causes and genomic alteration associated with cancer among Black Africans. Only 0.016% publication on cancer genetic and genomic are from the continent, and the publication represent breast, colorectal, liver, and bladder cancer were the most frequent. Most studies on cancer genetics in Africa are clustered to the North Africa region, South Africa, and Nigeria. And the most studied genes in the publication were BRCA1, BRCA2, TP53, EGFR, and MLH1. I was able to retrieve 3 publications about the genetic of inherited cancer in Rwanda, screening of germline mutation in young Rwandan patients with breast cancer, and 2 other publications published by the same author, association of between glutathione peroxidase, 1 codon variant, and the occurrence of breast cancer in Rwanda, and check 2 germline mutation are lacking among familiar and sporadic breast cancer patients in Rwanda. The 3 publications were about variants in Rwandan women with breast cancer, and Habyarimana conducted this research in 2018 in 41 women with breast cancer using Sanger sequencing. He looked for mutation in CHEK2 and glutathione peroxidase gene, but he didn't find any mutation. Uyisenga and the collaborators screened 40 Rwandan breast cancer in 2020 using next generation sequencing analysis. She was able to retrieve 4 pathogenic variants in BRCA1 and BRCA2 and the TP53 genes. And she's also reported 33 variants of uncertain significance. What is the state of genetic testing of inherited cancer in Africa? So in Rwanda, there is no available molecular testing and screening in Rwanda. We have limited research of samples sent outside. A center of human genetic opened in 2006. Only karyotype available. Most of the patients consult for congenital abnormalities, and few patients sought genetic counseling related to genetics, to cancer genetics, sorry. So genetic services are available in many countries. However, formal genetic counseling and training programs are only available in South Africa. Genetic testing inherited cancer are available mostly in North Africa and South Africa. Cancer policy in Rwanda in July 2018, the National Cancer Registry was established, and in February 2020, the Cancer Unit launched the country 5-year National Cancer Control Plan. So the goal of this plan was to reduce cancer-related mortality and morbidity in Rwanda. The planning, implementation, monitoring, and evaluation of the plan are to reinforce the following area: commitments, integration, equitable access, evidence-based, health system partnership, education, and patient awareness. So Rubagumya and collaborator published a study about the state of cancer control in Rwanda, past, present, and future opportunities. Here we have a table with 10 strategic priorities for the Rwanda cancer system in the next 5 years. And the third is to upgrade pathology services to incorporate immunohistochemistry and molecular testing for improved cancer diagnosis and prognostic. So the ethical legal framework existing in Rwanda. First of all, in Rwanda, researchers are required to submit their application to the Rwanda National Ethics Committee for approval. Of course, the patient has to consent before being enrolled in the study. So the cancer is managed under the non-communicable disease divisions. So the government put in place institutional and policy mechanisms to control and manage NCDs. We have institutional framework at the level of the Rwanda Biomedical Center. For example, in 2011, the establishment of the non-communicable disease divisions, even that divisions has made some advocacy about that various medicine to treat cancer must be included in the community-based health insurance. We have also legal and policy framework. For example, establishment of Butaro Cancer of Excellence and the first cancer center with radiotherapy at the Rwanda Military Hospital in February 2020. However, we not yet have legal framework regulating cancer genetic and genomic research in our country. So what else in other, what is the situation in the other countries of Africa? We have found also that there is a gap in knowledge existing regarding application of national and international ethical guidelines for genomic research in Africa. But also we have lack of genetic counselors and other healthcare professionals with experience in genetics and genomics. And also in the context of the culture in Africa, we have to take into consideration respect for human diversity, religion, cultural and social belief, and psychosocial well-being. Here we have an example of South Africa where Schumann and collaborators described an approach to implement breast cancer genetic counseling in Cape Town, and they face some challenges such as relative complexity of the risk assessment and testing approach, limited financial and human resources, limited community knowledge of breast cancer or of the possibility of a family cancer, difficulty accessing all the hospital records of family member. The other big barrier related to the ethics and the culture context in Africa is the language barrier. We also need to take into consideration socioeconomic status. Even we have some example where illiterate patients may think that signing a consent form for research is part of their treatment regime. Sometimes have not equivalent translation in the native African language, for example, DNA genes. We have also limitation of cultural barrier, where the diagnosis of cancer in the African community is perceived as a death sentence or a curse to the family. The patient sometimes worries about the effect of social stigma, may delay treatment, genetic testing in order to protect their family from stigmatizations. Even some conditions, participants may avoid declining the request for voluntary research participation openly when the researcher is seen as a part of hospital setting to ensure continued benefit from the institution. Another big challenge is the return of research result. There is a lack of documentations on return of research result in rural African setting. The result disclosure is usually done by treating physicians who sometimes have limited knowledge in genetic and genomics. The incidental or unforeseen result from secondary data analysis are challenging to address. High risk of unforeseeable harm to participant, family, and communities. Here, I found an interesting paper published by Zong and collaborator about the ethics and social and cultural issues related to clinical genetics testing and counseling in low middle income country. I found that this systematic review where they propose a special model can be applied in implementations of genetic services, even in case of cancer inherited disease. So the author make a systematic review of ethical, social, and cultural issues related to clinical genetic testing and counseling in low and middle income countries. So their thematic analysis revealed the 9 key themes: 2 ethical, 4 social, and 3 cultural. So then they proposed a social ecological model for improvement of genetic services. So the 9 themes were mapped into the 5 levels of the social ecological model. Individual, where patient, socioeconomic status, religion's principle, cultural belief, and psychological well-being has to be considered. Interpersonal, which is the effect of family value, psychological effect on family member, marriage prospect, and directive counseling. Institutional, genetic services provision and affordability, lack of clinical guideline for genetic counseling, lack of psychosocial support, and the eugenic tendency of genetic services. So we have also social stigma of individual and family with genetic disease, religious principle, and cultural belief and practice, which is related to the community. And finally, we have public policy, which involved inadequate medical training, guidelines, and healthcare costs for genetic services. I found that all these can be applied in a context of cancer genetics also in Africa. So why we need, even though we are facing many challenges, there is a need to implement genetic testing of inherited cancer in Africa, because most of the genetic data are from non-African population. There is a wide knowledge gap in understanding the underlying genomic alteration associated with cancer among the Black African. People of Africa are the most genetically and phenotypically diverse populations. Genomic sequencing will provide data to apply precision medicine in Africa. So what has to be done in the future to implement or to enforce cancer genetics in our continent and even in our countries? There is a need of integration of genetic services into healthcare levels, need to build capacity in cancer genetic awareness, advancing genomic health education, which more in-country training programs are needed, promotion of ethical reflection on research processes in Africa, engaging policymakers allocating appropriate fundings, and establishment of national cancer registry and strengthening existing facility for cancer diagnosis and treatment. So in conclusions, after we have realized there is a wide gap knowledge in understanding the underlying genetic cause and genomic alteration associated with cancer among Black African. Breast cancer is the most studied inherited cancer. There is no legal framework regarding cancer genetic and genomic research in Rwanda. So many relevant ethical, legal, and social issues in implementing cancer genetic in Africa. and there is a need of implementing genetic testing of inherited cancer in Africa. I would like to thank the Rwanda Biomedical Center. I would like to thank the CHK and the University of Rwanda for their contribution to this presentation. Thank you very much.